Good afternoon and welcome to our Cardiac and Vascular Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative session. I would like to extend warm greetings to our friends and colleagues joining us today from across Latin America, the Caribbean, and around the world. Today's lecture will be interactive. You may submit your questions at any time using the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. It is my distinct pleasure to introduce our distinguished speaker, Dr. Bryan Wilner, who will be presenting Don't Let the Heart Miss a Beat, From Diagnosis to Treatment. Dr. Bryan Wilner is a cardiac electrophysiologist at Baptist Health Miami Cardiac and Vascular Institute. He specializes in cardiac electrical system disorders and is a board-certified in internal and cardiovascular medicine. His areas of interest includes catheter ablation and medical management of complex arrhythmias, cardiac device therapy, and left atrial appendage closure. Dr. Wilner earned his medical degree from the University of Miami Miller School of Medicine and completed his internal medicine residency at the University of Texas Southwestern Medical Center. He then completed his specialty and subspecialty training at Cleveland Clinic in Ohio with a fellowship in cardiovascular medicine, followed by a second fellowship in cardiac electrophysiology. Please, let's give a warm welcome to Dr. Bryan Wilner. Dr. Wilner, what a pleasure having you in today. Thank you so much for your time. The floor is yours. You may go ahead and present your PowerPoint.
Of course. Thanks, Dr. Hakim, for letting me talk today. So the title of my presentation is Don't Let the Heart Miss a Beat, From Diagnosis to Treatment. And really the goal of the presentation is just to give you all a sense of the field of electrophysiology and what we do. We have a joke that electrophysiology is kind of like the black box of cardiology. No one really knows what we do, so I'm hoping to demystify that. So my agenda today is I'm going to talk briefly about just basic principles of electrophysiology, discuss briefly common arrhythmias. I'm then going to walk us through two cases, the first one being a patient who presents with heart block and how we manage that, and then a patient who presents with atrial fibrillation and how that gets managed.
That's wonderful. Dr. Wilner, would you try again and see if the PowerPoint comes up?
Can you see it now?
Not yet. Take your time. Now it's coming. You can put in presenter mode and you are on. Thank you so much.
Perfect. Let me just repeat what I said. I'm not sure. So I'm going to talk about basic principles of electrophysiology, focusing on the title of my talk, Don't Let the Heart Miss a Beat, From Diagnosis to Treatment. And I'm going to just walk us through different cardiac electrophysiology principles. I'll discuss briefly common arrhythmias and then go through two cases, specifically how those get managed. So just in terms of electrophysiology and the basics, again, what we're dealing with is with arrhythmias. So arrhythmias are abnormal heart rhythm, which is characterized by either an irregular heart rhythm. It can be a heart rhythm that's too fast or too slow. Here on the left is just an image of the electric system. So the way electricity works in the heart is impulses originate in the sinus node. They then conduct through the atrium down to the AV node. They then conduct down to the ventricle through the right bundle branch and left bundle branch. And really abnormalities or diseases can happen in any aspect of this tree. So bradyarrhythmias, as we know, are when heart rates are too low. This can be due to sinus bradycardia or what's known as heart block, which is more dangerous. So there are different types of heart block, second-degree heart block and third-degree heart block. And now I'm going to take us through a case to discuss how we manage that. So this is an 86-year-old male with a past medical history of hypertension who presented to the ER after an episode of abruptly passing out. His labs showed that his hemoglobin was normal, his electrolytes were normal, and his troponin was mildly elevated. Here you can see his EKG, and most obvious is that his heart rate is low. So, sorry, give me 1 second. His heart rate is 38 beats a minute. And then here you can see I have arrows to show where the P waves are. And we see that there's no relationship between the P waves and the QRS. And this is known as what's called complete heart block. So complete heart block is when electric signals generated in the atrium do not conduct down to the ventricle, and you have complete dissociation between the electricity in the top chamber of the heart, the atria, and the bottom chamber, the ventricles. In terms of how we treat this disorder, first off, we have to rule out reversible causes. Common reversible causes of complete heart block include electrolyte abnormalities, ischemia, medications such as AV nodal blocking agents, beta blockers, calcium channel blockers, digoxin toxicity, or patients who are on some antiarrhythmic medications. Sometimes infection can cause this, hypothyroidism. And then the ultimate treatment for heart block is what's known as a pacemaker. So when we talk about pacemakers, there's really two major different types of pacemakers that we can implant in patients. The first one is known as a transvenous pacemaker here on the left side of the screen. And this is where a pacemaker is put in through the subclavian vein, and then wires are placed in different areas of the heart, the atrium, the ventricle, and sometimes placed in the coronary sinus. More recently, in the last several years, there's been several what are known as leadless pacemakers that have been developed, and these get implanted through the femoral vein up the IVC into the right ventricle. There are nuances in terms of how we decide which pacemaker is best for a patient, but nonetheless, these are two excellent options. Next up, I'm going to talk briefly about tachyarrhythmias. So when the heart rate beats too quickly. So there's two different types of tachyarrhythmias. The first is known as supraventricular arrhythmias and then ventricular arrhythmias. In terms of supraventricular arrhythmias, or what are known as supraventricular tachycardia, this is again when the heart rate is when the heart is beating too fast. There are several different mechanisms for why this can occur. The most common is known as atrial fibrillation, which is an irregular heart rhythm, which I'm going to talk about more in detail. Atrial flutter is when we have a circuit in the top chamber of the heart, and in the perfect scenario, it can get going, and that can cause atrial flutter. Next up, we have atrial tachycardia, which is where there's a very focal area in the top chamber of the heart that's beating very fast. AVNRT is a common arrhythmia seen in younger patients that are otherwise completely healthy, where there's actually an extra electric circuit in the normal conduction system, which can result in the heart rate beating very fast. And then AVRT, or AV reciprocating tachycardia, is where you have an extra accessory pathway in the heart. And again, in the perfect scenario, a circuit can form and that can lead to tachycardia. Next up, we have a 60-year-old male with a past medical history of hypertension and diabetes who presents with 2 weeks of palpitations and shortness of breath. This is his EKG. What you see here is that it's an irregular heart rhythm and there's no visible P wave. So this is known as atrial fibrillation. I'm next going to talk about briefly how we diagnose atrial fibrillation, pathophysiology of atrial fibrillation, and then different treatment options. So atrial fibrillation is known as a cardiovascular epidemic. It's the most common arrhythmia that we treat, and the incidence and prevalence has been increasing tremendously over the past 20 or so years. In terms of pathophysiology of atrial fibrillation, what we see here is an image of the heart. This is the left atrium. These are known as pulmonary veins. And atrial fibrillation is due to irregular electric activity that originates within the pulmonary veins. Why is atrial fibrillation dangerous? Well, there's several reasons. One, it can increase the risk of stroke. So when the top chamber of the heart, the atrium, is fibrillating, blood is not moving well through the atrium. And when blood doesn't move well, this can lead to clots forming. If a clot formed in the heart and got pumped out of the heart, it could go to the brain, resulting in a stroke. Next, atrial fibrillation can increase the risk of heart failure. There's been studies to show that patients who have atrial fibrillation have a decrease in quality of life, and that's been correlated with burden of atrial fibrillation. There's been newer studies that show in patients that have been in long-standing persistent atrial fibrillation or in atrial fibrillation for many years, the blood flow to the brain is different. And there's been recent studies showing correlation with dementia. Patients with atrial fibrillation also have structural remodeling of the heart. So the longer someone is in atrial fibrillation, that can lead to dilation of the top chambers of the heart, the atrium. And when the atrium starts to dilate, this leads to more atrial fibrillation. But what it also does is it can pull the valves out as it dilates, and it can lead to mitral regurgitation, tricuspid regurgitation, and this also ultimately can result in heart failure. So in terms of how we think about atrial fibrillation management, obviously, first up, it's very important to make a good diagnosis. And then once a diagnosis is made, we talk about the importance of early rate versus rhythm control and stroke prevention. And one aspect of all effective atrial fibrillation management is risk factor modification. Risk factors for atrial fibrillation are similar to risk factors for all aspects of cardiovascular health. So obesity, a lack of fitness, hypertension, alcohol use, smoking, diabetes, and sleep apnea. In terms of how we manage atrial fibrillation, the first off is, whether someone should be managed with rate controlling agents, so medications that would lower the heart rate, or with rhythm control. Rhythm control means taking someone who's in atrial fibrillation and putting them back into normal rhythm. Different options for rhythm control include medications such as antiarrhythmic medications, and also with a procedure called an atrial fibrillation ablation, which I'm going to touch on briefly. Other than rate versus rhythm control, stroke protection is one other extremely important aspect of atrial fibrillation management. In terms of stroke protection, there's two options of how we do that. One is with anticoagulation medications, or there's an alternative known as a left atrial appendage occlusion device, which I'm also going to briefly talk about. There's really been a paradigm shift in the past several years in terms of how atrial fibrillation gets managed. And our new guidelines that were published in 2023 really emphasize the importance of maintaining sinus rhythm and minimizing AFib burden. This is a multi-center observational registry that looked at stroke risks based on the type of atrial fibrillation. It was a very large registry with over 8,000 patients. And what it did is it looked at the cumulative incidence of stroke over time in patients with atrial fibrillation. It categorized patients as having either paroxysmal atrial fibrillation, which means they go in and out of atrial fibrillation. So sometimes they'll be in atrial fibrillation and other times they'll be in sinus rhythm. And then there's what's known as non-paroxysmal AFib or persistent atrial fibrillation. And these are patients whose atrial fibrillation has progressed to the point where they're in atrial fibrillation all the time. And it just followed them over years and looked at incidence of stroke. And what it found is that non-paroxysmal atrial fibrillation is associated with higher risk of stroke. So the conclusion is that if we can prevent progression to persistent atrial fibrillation, then maybe we can decrease the risk of stroke in patients. These are several trials that have been published in the last several years that show superiority of early rhythm control and the importance of actively taking patients out of atrial fibrillation and putting them back into normal rhythm. The first trial was known as the East AF trial. This was a trial that was published in the New England Journal of Medicine in 2020, and it looked at early rhythm control therapy in patients with atrial fibrillation. So what they did is they took around 2,700 patients with early diagnosis of atrial fibrillation, and they were diagnosed to early rhythm control versus usual care. And the primary outcome was composite of CV death, stroke, hospitalization with heart failure, or ACS. And what it showed was that early rhythm control was superior to usual care. So this was the first trial that was published about 5 years ago that really started shaping how we manage atrial fibrillation and contemporary and the importance of early rhythm control. The next trial was known as the Stop AF trial. So this looked at saying in patients who have atrial fibrillation, what is a more effective way to achieve rhythm control? Antiarrhythmic medications, such as medications like amiodarone, dofetilide, flecainide, versus performing an atrial fibrillation ablation on these patients. And they were followed over 12 months. And what it showed was that atrial fibrillation ablation was much more effective in preventing recurrence of atrial fibrillation compared to drug therapy. This trial led to the approval of ablation as first line without having to fail antiarrhythmic therapy in patients with atrial fibrillation. Next, there was the Castle AF trial, and this trial looked at patients with heart failure with reduced ejection fraction, so EF of less than 35%, who had atrial fibrillation, and they did ablation versus medical therapy, and there actually was a mortality benefit in these patients if they underwent atrial fibrillation ablation. So, these are just several trials. There's many others that I don't have time to discuss today, but nonetheless, the conclusion is that early rhythm control with ablation prevents progression of atrial fibrillation, and there's actually a mortality benefit in performing an atrial fibrillation ablation in patients with heart failure. So from conclusions from multiple of these studies, ablation has become first-line therapy in patients with atrial fibrillation based on multiple randomized controlled trials. Ablation for AFib is more effective than putting patients on antiarrhythmic therapy for both patients with paroxysmal and persistent atrial fibrillation. An earlier implementation of a rhythm control strategy is an important factor for improving atrial fibrillation ablation success rate. Again, this is just a pathophysiology of atrial fibrillation. And again, it's due to chaotic electric misfiring of electricity that originates from within the pulmonary veins. So what we do during an atrial fibrillation ablation is called a pulmonary vein isolation. So this is an electroanatomic map that gets created during an atrial fibrillation ablation. And what we're looking at here is the left atrium. This is looking at the backside of the heart. So this is the posterior wall of the left atrium. This is the left superior pulmonary vein, left inferior pulmonary vein, right superior pulmonary vein, right inferior pulmonary vein. And again, the pulmonary veins are where atrial fibrillation originates from. So what we do during an atrial fibrillation ablation is called a pulmonary vein isolation, where we deliver ablation lesion points around the pulmonary veins, essentially to create almost like an electric fence around these veins to prevent any atrial fibrillation that were to start in the pulmonary veins from leaving the pulmonary veins, and thus decreasing the risk of the atrium going into atrial fibrillation. This is just a video of exactly what we're doing during an atrial fibrillation ablation. So again, we have a catheter in the heart. So the way that gets there is we get access to the femoral vein. The catheter goes up the IVC into the right atrium, and then we go transeptal to the left atrium. What I'm doing here is the beginning of the procedure. I'm creating an electroanatomic map of the left atrium and identifying all the pertinent aspects of anatomy for an atrial fibrillation ablation. So here my catheter is moving around the left atrium. On the left side, you can see this again is the left inferior pulmonary vein, the left superior pulmonary vein. This is the right inferior pulmonary vein and the right superior pulmonary vein. So the first aspect of an ablation is we identify all those important landmarks for the procedure. Next up, what we're going to do is the pulmonary vein isolation. So what you see here is I'm creating ablation lesion sets around the pulmonary veins. And what this is doing is actually creating scar tissue in this area. So electricity in the heart does not travel across scar tissue. And again, the analogy that I explain to patients is that we're basically creating an electric fence around the pulmonary veins, and that prevents any atrial fibrillation that is known to originate from within the pulmonary veins from leaving the pulmonary veins, and that decreases the ability of the heart to go into atrial fibrillation. So we first create that electric fence around the left-sided veins. We then move the ablation catheter to the right-sided veins, and again, we create that electric fence, or basically scar tissue, around the pulmonary veins. After the pulmonary vein isolation is performed, we have to check our work. So again, what we're looking at here is the left atrium. This is the backside of the heart. So right now, the ablation catheter was just, right now it's in the left superior pulmonary vein, and then here's a left inferior pulmonary vein. This is after we've done the atrial fibrillation ablation, and what we do to check to make sure that that all the important points are isolated is that the ablation catheter gets placed back in the pulmonary veins, and we make sure that no electricity can go into the vein, but also that no electricity that starts in the vein can leave the vein. And this final picture here shows an effective atrial fibrillation ablation pulmonary vein isolation, where all 4 pulmonary veins are completely electrically quiet, and then here's the posterior wall, which is healthy, which is what we like to see. So in conclusion from this, ablation works and ablation is safe. Next off, I'm going to talk briefly about stroke protection in patients with atrial fibrillation. So whether we decide whether someone needs to have management for stroke protection and atrial fibrillation is based on what other risk factors or comorbidities do they have. There's a well-established risk score we use called the CHADS-2 VASC, which just looks at, again, what risk factors an individual patient has and whether they meet criteria for being on anticoagulation. So risk factors include heart failure, hypertension, age, diabetes, thromboembolism, vascular disease, and sex category, specifically female. So if the risk of stroke is greater than 2% per year, so that's a CHADS VASC of 2 or greater in men or 3 or greater in women. And when I say 2 or 3, that's just related to how many risk factors they have, then anticoagulation is recommended for stroke protection. However, we've seen that there's limitations of placing patients on anticoagulant medications. We know that there's increased risk of bleeding. Many patients have anxiety about taking blood thinners. These medications are extremely expensive for patients, and because of this, compliance is not very high. There was one study that showed that a quarter of patients may stop taking anticoagulation within a year of starting it. So because of that, we've asked, are there potential alternatives to anticoagulation if patients don't want to be on it? And the answer is yes. What's known as left atrial appendage occlusion devices. So what are these exactly? So the left atrial appendage is an outpouching of tissue in the left atrium. So here's the left atrium, and the left atrial appendage is right here. It's this little outpouching of tissue. And because of this little outpouching of tissue, blood flow is not good in this outpouching, especially when patients are in atrial fibrillation. And because of this, this is the most common site that clots form in patients who have atrial fibrillation. And again, if a clot formed here and it embolizes, it could cause a stroke. So what left atrial appendage occlusion devices are, the most common one is known as the Watchman device. It's a device that's designed to essentially occlude or close the left atrial appendage, and thus this reduces the risk of stroke. This right here is the left atrial appendage occlusion device, and it allows patients to stop anticoagulation, which can reduce the long-term risk of bleeding, but it also gives them stroke protection. So when is the Watchman device an option? So again, in patients with AFib, they have to have a moderate to high risk of stroke. So again, that's a CHADS VASC of 2 or more in males or 3 or more in females, and have a contraindication for being on long-term anticoagulation. Either they're at high risk of falling, they've had prior falls, they've had prior bleeding in their brain, GI bleeds, nosebleeds. There's many different reasons why a specific patient may not be suitable for long-term anticoagulation. More recently, there was a trial that looked at is the Watchman an option in patients who don't have a high bleeding risk? And what it showed was they took patients that underwent an atrial fibrillation ablation and they randomized them. Half of them stayed on a blood thinner for over the study period, which is 3 years, and the other half stopped the blood thinner and they got a Watchman and they followed them over time. And what it showed was that the Watchman device is just as effective as being on an anticoagulant and decreasing the risk of stroke, but also that there was about a 17% decreased risk of bleeding over the time period. So because of that, the Watchman has now started to become an option in patients with atrial fibrillation beyond the standard recommendations previously was that they had to have had a real reason to not be on anticoagulation. This is a video showing exactly what we do during a Watchman procedure. So Again, we get access to the femoral vein. The catheter is placed up into the IVC, into the heart. We then go transeptal, which is what we're doing right now. Right now, we're in the right atrium. We're going across to the left atrium. Here you can see that the Watchman sheath is in the left atrium. So now we have to navigate to the left atrial appendage, which we do here over a pigtail. There's a left atrial appendage. We then deploy the Watchman device, which basically gets unsheathed, almost like an umbrella that opens up. And that's how the device sits. After the Watchman is deployed, there's a very strict criteria that has to be followed to say that the device is in a good position. It's not going to move. There's no leak anywhere. And then the device gets released. So in conclusion, early recognition of arrhythmias is key to effective treatment. There's all different types of arrhythmias, and all different physicians from all different specialties are the initial physician that is going to recognize these arrhythmias, and it's extremely important to have good collaboration and importance of multidisciplinary care, and really for us as electrophysiologists to go out in the community and again to educate physicians and healthcare professionals on diagnosing these arrhythmias, because they're the first line to getting these patients appropriate treatment. So let's keep hearts in rhythm, and thank you so much for letting me present today.
Thank you so much, Dr. Wilner. What a phenomenal presentation. So succinct, but so important, because you mentioned several important things that I would like to actually dive in, and so you can help us understand a little more, especially for our student doctors. Obviously, you mentioned something extremely important that it just brought me back. And it's the fact that if we do not do anything about heart failure, most likely we're going to have obviously other conditions such as congestive heart failure that will ensue if we don't treat it timely. And then, of course, one of the ways to actually look at the management of heart failure is the risk factor modification, which is like what comes first, the chicken or the egg kind of thing for some doctors. Obviously, we encounter always obese patients or hypertensive patients or smokers, alcohol drinkers, and so on and so forth. So modifying that, perhaps it's one way, one avenue. But what if you get a patient already that is let's say at the early stages of congestive heart failure, that was
AFib.
secondary to age.
Oh, I'm sorry. Okay, sorry, go ahead.
That comes to you with congestive heart failure, but known to have had AFib at some point. How do you manage these patients? Do you take first the congestive heart failure, deal with that, and then address the AFib, the fibrillation?
Yeah, that's a
How does
great
that work?
question. So absolutely. I tell all my patients, if the only physician managing your atrial fibrillation is an electrophysiologist, then we're not doing a good job. Okay. So atrial fibrillation, again, is one aspect of a patient's overall health. And absolutely, patients who have atrial fibrillation likely have risk factors for the atrial fibrillation, as well as risk factors for all aspects of cardiovascular care, which is why it's so important to have a multidisciplinary approach to treating all these patients. So anytime we see patients with atrial fibrillation, and we talk about our specialty in terms of the rate versus rhythm control and stroke management, but also the risk factors have to be controlled and treated as well, or you're never going to get effective atrial fibrillation management and effective rhythm control. So specifically in patients with heart failure, which you talked about, you're right. Is it the chicken or the egg? Which is causing which? And I don't think we'll ever know. There's some patients who have uncontrolled atrial fibrillation with fast heart rates, RVR, for several weeks or months. And that can lead to a tachycardia-induced cardiomyopathy, where basically the heart muscle just gets tired from beating so fast. And a lot of times those patients, if you focus on early rhythm control and get them back in normal rhythm, their heart function will return to normal. But there's also other patients who have heart failure from other reasons. They've had either prior MIs or non-ischemic cardiomyopathies. And just from the progression of that, that can lead to atrial fibrillation as well. And the reality is, in patients who have heart failure, AFib is not good for it. It doesn't matter if it's the chicken or the egg, they do better in normal rhythm.
Hmm. Yeah, definitely. Has always been a conundrum, especially for internists or primary care providers that manage these patients. They identify something, but for whatever reason, we don't follow through, or we immediately refer to a cardiologist. They start them on anticoagulation just for the sake of doing that, and then other complications will ensue. I love the fact that you talked about the Watchman. This has also been somewhat of a conundrum for many patients that have heard of the Watchman, because obviously it's being publicized on TV, and people are interested or not actually learning about it. I am so happy that you touched on that specifically, because as you know, we always have such a hard time managing anticoagulation for patients. You send the patient, let's say, like in the old days, you send them on Coumadin, and then what happens? How do we monitor the level? Who is going to monitor? Is this patient going to bleed to death, or so on? So
Hmm.
these a particular alternative and these technologies that you guys are using currently, it is absolutely fantastic. In your experience, has that diminished the risk of for those patients on anticoagulation? And do you promote it as, you know what, let's stop anticoagulation and let's go through Watchman instead? How do you determine that?
Yeah, that's a great question. So I think the indications and who we're offering the Watchman device to definitely has increased recently. And the reason is, which I touched on briefly, traditionally the Watchman was only approved for patients that cannot tolerate a blood thinner. So either they had had a major bleeding episode, they had prior falls, but otherwise those were the only patients that could get a Watchman. The field is changing tremendously for
Mhm.
several reasons. One, which I touched on briefly, there was a big randomized controlled trial called the Option Trial
Right.
that came out in New England Journal of Medicine last year that showed that patients that just don't want to be on a blood thinner because they know there's increased risk of bleeding and for whatever other reason, and those patients got Watchmans and they did just as well, or you could argue they did better than the patients who stayed on a blood thinner because their bleeding risk was decreased by 17%. So that's one. And then two, there's certain patients where we've actually started doing what's called a concomitant procedure. So
Mhm.
we do an atrial fibrillation ablation and the Watchman during the same procedure. So that saves a
Oh,
lot
wow.
of patients potentially a second procedure, and that gets them off of their blood thinner quickly as well. One aspect I didn't touch on with any of these procedures, the atrial fibrillation ablations or the Watchmans, is that these are fast procedures. Patients start to finish, the procedure is 1 hour, 1 hour and a half. They're outpatient procedures. Patients usually leave later that day. I've had several patients after an AFib ablation ask me if they can go out to dinner the same night. So the patients, they recover tremendously fast and they're back to living their normal life the next day.
So exciting. All the advancements that you guys have actually had. The first time I saw a pacemaker that looked like a capsule, even smaller than a huge vitamin E, it was mind-boggling when one of our doctors, one of your peers, actually took one as a sample to a conference. And like that, obviously, we're looking forward to actually using these devices to actually do some remote monitoring. Is that something that we already have in place at MCVI?
Great question. And absolutely, yes, we do. So all of our patients, once they get pacemakers, they get enrolled in what's called remote monitoring. So the pacemakers collect a lot of data on patients, okay? Without getting too much into the nuances,
Yeah.
basically they can record data on if patients are having arrhythmias, if they have atrial fibrillation, if they have different arrhythmias, and that data gets stored in their pacemakers and actually gets transmitted over to our remote monitoring clinic. And then, that's another way where patients get diagnosed with different arrhythmias. But we have a full remote monitoring clinic at Baptist that's staffed by nurses, and there's a whole protocol on how it gets managed. But yes, all these patients get enrolled in remote monitoring, and we are monitoring the devices to make sure they're working appropriately.
That's fantastic. And what about this noise about new devices that are compatible with MRIs? Do we have that in the market already?
We do. So the pacemakers and
Yes,
defibrillators, the
pacemakers. Yeah,
newer
yeah.
one, yeah, pacemakers, they are compatible with MRIs. Some of them require you have to wait a few weeks before getting an MRI, but absolutely all the new devices that that we place are MRI compatible.
It's absolutely crazy what you guys have accomplished. That's wonderful. I have a question from Dr. Chavez, and it says, obviously, he's congratulating you on the wonderful conference. And he says, what clinical criteria or patient profiles guides your decision to transition from standard ambulatory ECG monitoring to an implantable loop recorder for continuous arrhythmia detection?
That's a great question. So yeah, what the question is alluding to is who do we put loop recorders in? So loop recorders are small devices about the size of a USB, that gets put in a computer, and they can get placed under a patient's skin on their chest. And basically, it allows for long-term continuous monitoring to look for heart rhythms. The devices stay in for about 3 years, and it gets managed through a device clinic. So the patients that benefit from loop recorders are several. One is patients who have had an ischemic stroke of unknown etiology. Atrial fibrillation is a very common cause of that, but we just haven't caught it yet in that patient. So many patients who have ischemic strokes of unclear etiology are candidates for loop recorder implants. Other patients that are candidates for loop recorder implants are patients who have infrequent episodes of syncope. So it's too difficult to put a 48-hour monitor or a 14-day monitor or even a 30-day monitor, because they just may not have that episode of syncope during that time. So those are another group of patients that benefit from loop recorders, and that patient may have transient heart block, and that's causing the
Mhm. Sure.
syncope. Other patients where we sometimes put loop recorders in are after atrial fibrillation ablations to monitor long-term for recurrence of atrial fibrillation, as there's certain patients where that would dictate whether or not they need to be on a blood thinner long-term.
Amazing. In your experience, what are the main predictors of success in catheter ablation for paroxysmal versus persistent atrial fibrillation?
That's a great question. So the one big theme of electrophysiology and atrial fibrillation management is that early diagnosis, early ablation leads to better outcomes. So, what the clinical trials have shown is that diagnosis to ablation within 1 year results
Mhm.
in better arrhythmia free over time. However, the way that I extrapolate that is that the earlier you ablate someone with AFib, the better the chance of success, decreased risk of recurrence.
I see. One last question, doctor, because we are full of questions for you today. How do you approach the indication of prophylactic ICD implantation in patients with borderline ejection fraction or MRI evidence of myocardial fibrosis, but not documented arrhythmic events?
Okay, that's a great question. So the question is looking at what are indications for ICDs essentially. So
Mhm.
there's many different indications for ICDs. The most common is someone who has heart failure with reduced ejection fraction less than 35% on guideline directed medical therapy. So again, there's a very specific um, medication. There are very specific medications that get used in patients with heart failure. So if they've been on those medicines greater than 3 months and they continue to have an EF less than 35% and their NYHA class 2 or greater, they would meet an indication for an ICD. The specific question here is if the EF is just borderline reduced, but there's scar. I think the question comes down to whether are they having episodes of ventricular tachycardia? Are these sustained episodes, so greater than 30 seconds? The question of just the EF being mildly reduced with scar does not get you an ICD just based on that.
I see, I see. Dr. Wilner, if I was to ask you, what are you most excited about in regards to technology for the future, what comes to mind first?
Great question. So one of the super exciting aspects of the field of electrophysiology is that the technology is always changing. There's always new devices coming out, new ways that we approach stuff. So for example, on the device side, like I said, the leadless pacemakers is a huge, exciting new tool that we have. And then on the ablation side, I didn't touch too much on this, but one very exciting aspect of atrial fibrillation management is the energy source we're using to ablate now. So traditionally, the way that atrial fibrillation ablation was done was with either burning tissue, radiofrequency energy, or freezing, cryoablation. And while this was very effective, there were some rare but potentially very serious complications. So when you ablate on the backside of the heart, that's just in front of the esophagus. So we would have to be very careful about heating the esophagus, and that would limit how much we could ablate on the backside of the heart because there's risk of aortoesophageal fistulas, which are fatal complications. Also, when you either burn or freeze tissue, you have to make sure that you're not near the phrenic nerve when you ablate. You could damage the phrenic nerve or get what's called pulmonary vein stenosis, which can be very serious. So I want to say about 2 to 3 years ago, a new ablation energy source became available known as pulse field ablation, which is what we use now for our atrial fibrillation ablations. And what this energy source is it doesn't burn or freeze tissue. It actually creates an electric field, and the frequency of that electric field is specific for damaging just cardiac tissue. But the reason that is so exciting is that it doesn't have any of the potential risks of the traditional thermal energy sources. So it doesn't risk damaging the esophagus, it doesn't risk damaging the phrenic nerve, it doesn't risk damaging the pulmonary vein. So now atrial fibrillation ablations have become safer procedures, and there's newer data to actually show that this new energy source, again, it's called pulse field ablation PFA, might be more successful long-term than the traditional thermal energy sources. So this is a huge step in the field, and every electrophysiologist is so excited about this.
And we are excited for you, Dr. Wilner, and for your colleagues, and especially for our patients. This is going to change completely the way we treat AFib, obviously, and change the paradigm in the way we have learned to treat historically these kind of conditions. Thank you so very much for everything that you do. And I want to thank you for this amazing conference and for answering our questions today, Dr. Wilner. For this incredibly informative presentation. For all of you that participated today, thank you for your questions. Please feel free to send your additional questions, or if you are intrigued about something in regards to this amazing technology that Dr. Wilner and his team uses, please send us an email at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We'll make sure to send those questions to him in order for him to respond, and we'll send them back to you. If you do have patients that require assistance, or you consider that they meet the criteria for any of these devices, please send them our way. We will be more than happy to conduct a second medical opinion together with Dr. Wilner to see if we can assist you immediately. Quality of life is what he and his team and all of us we're after. Therefore, it is a great opportunity to have this link with Dr. Wilner. We look forward to seeing you all in our next cardiac and vascular lecture series. We will be scheduling that in future weeks. Thank you once again, and have a wonderful afternoon. Thank you, Dr. Wilner. Great seeing you.
Thank you.